Dear colleagues, dear students, and dear maybe my followers, friends, everybody who is here. If you don't know me and see me the first, my name is Victor, my family name is Kostiuk, and today I will have a meeting with you and will speak about my life, my specialty, my experience. And I'm very thankful for organizers of our meeting. It is my alma mater, my native university that I finished in 2008, and I'm happy and proud to be here. I would like excuse maybe I do some mistakes, but I think it is not too bad because I'm original Ukrainian guy. So all right, let's go. First slide. Go. The plan of our meeting, it is about me. I will speak about my life, my experience. Maybe this information will help you and you will do something different because maybe I will change your things. Then later we will speak about neoplasm of bones, soft tissue of extremities. If somebody doesn't know what is it extremities, in English language we call this upper and lower limbs. In more simple words, it is hands and legs. Then we will speak about epidemiology, classification, risk factor, diagnosis, what is a biopsy, what is a treatment plan, how we do it, the main types of surgery that we use in oncology, orthopedic, life forecast, why we should work together like an interdisciplinary team, commission, why in 21st century we have problems of diagnosis and treatment, why we have too late cases, too big tumors, and what we do in these cases. I will show you lots of different cases during surgery, during follow-up of my patients, and we will speak about future of modern oncology orthopedic. We'll make this conclusion, and of course I will be happy to see some questions. You can write them in chat in YouTube where you are now, and at the end of my lecture we will discuss some questions that you have already written. As you know, I'm Victor Kostiuk. At the moment I'm PhD in oncology. I'm orthopedist-traumatologist, oncologist, co-author of more than 60 scientific papers, 7 patents for inventions. I did it with a group of different colleagues from National Cancer Institute. It is the main place where I work now. My professional interest, it is treatment of diseases of musculoskeletal system. It is a joint replacement, treatment of bone and soft tissue tumors. And of course, I'm very interested in study of relationships and communication between doctor and patient because I believe that it is a very important part of our life and our job that we do actually. And of course, I have hobby like all of you, I hope so. I have my culinary blog, I cook food in Facebook, Instagram. Also, I like fishing, I love traveling. So, and like most of Ukrainian doctors and in the world, it is really popular too. I have some small things, my brands that I have my logo that you see on the screen, and of course I have a video. May you switch on video, please?
Я доктор Костюк. Моя робота – це боротьба за життя та рух без болі. Звертайтесь за...
Great, you know, I came to Medical University in 2008, and this time I couldn't know, I couldn't believe that 20 years later everyone doctor in Ukraine will think about private brand, that how we can go further to do lots of different things in social media, have own sites, make advertisement, work very hard to be a popular. It was completely different system, completely different aims that we have now. And now in Ukraine, everyone doctor, and I think so in your countries it popular too, have to be good brand, because people want to see a brands and the faces. They want to go to clinic that have a nice name, or doctors that popular and have a good recommendation. About me, I was born in 1984 in Western Ukraine, in small city, that population about 5,000. My dad, my father, he was a driver on the car, and my mother, she during all her career, she was a nurse, and she influenced me, and probably that's why I became a doctor. And recommendation of my friend when I was choosing university was to go to Kyiv Medical Institute 20 years ago, because this institution, the Medical Institute of Ukrainian Association Folk Medicine, now we call this Kyiv Medical University. I entered to university, as I told, in 2001, and one big reason why I came to here, because about 15 years ago in Ukraine was very popular for students and for medical institutions too, to go abroad to earn money. Sorry. And my family those time wasn't too rich, and we had money only for a few years of my education, and I and my parents, we had the aim that later I will go to United Kingdom to earn money. And I'm very thankful for Alexander Pokanevich. 20 years ago, Sasha Alexander was organizing the process of sending students abroad, and he helped me to get visa and documented permission to work in United Kingdom 2004. But embassy gave me visa too late, and I came to United Kingdom in July. But in July, the aim was to go there and pick up strawberries, but it was too late, and weren't too much job. I mean, no strawberries, no money, and was very short period until beginning of the studying year. I mean, 1st September, and I decided to stay in United Kingdom for 1 year. And after strawberry farm, I worked in the small city, in the pub. Then I went to London, and I have experienced many different specialities there. I was builder, I was postman, I was dishwasher. Then I went to some cities near Southampton, and we worked on a pigs, turkey and chicken farm. It was very good time with my friend. I got lots of good friends there. And I had idea to stay there for maybe a few years more, because that time I could speak English much better than now, because now I don't practice English every day, but in this time my English was much better. I knew how to find job, where to go, but my parents waited me here, and I had the big aim to become a doctor. That's why in 2005 I came back to Ukraine. After half year of education in medical university, you know that last year I was independent person. I earned my own money. I felt free, but when I extended to study again, it was some finances deficiency, and I decided to work to be more independent, because all money what I earned I gave to my family, and we used this for payment of my education. And I watched some papers, and I found place and restaurant in Kyiv that looked for English-speaking bartenders, and I came there for interview, and boss took me to work as a bartender in an Irish pub and restaurant Golden Gate. It is a photo, it is not from a Golden Gate, it is a photo from other restaurant that I worked. I was young, it was good experience. Restaurant business give us understanding of relationships with people. You can see and speak very successful visitors there, communicate with them, take some experience for them and use this in your life. And of course I met one guy, it is Robin Artwright. I hope, Robin, you see me here too. I worked for him in a Golden Gate Irish pub and restaurant for about 6 years. We have a very good friendship right now. As I'm a doctor too, we communicate. Sometimes I help him, and I'm very thankful him because in Ukraine it is really very difficult sometimes to find people who know something bigger than locals. I mean, what is that real service? What is that real team building, communication? And it is what was very important in my wife all time says that this man really influenced on my life and on my person who I am now. Thanks, Robin. See you. And in 2008 I came to internship to be orthopedics and traumatology. As you see, I like it skeletons, and I together with my friend, he is also doctor of trauma doctor in Kyiv district, and it was good time. But idea to be trauma doctor was born when I was student on second or third year, and it professional specialty was very close to me. I don't know why. My practical experience when I finished internship to be orthopedic and trauma doctor, it was very difficult, of course, to find some place of work, place where you can perform surgeries in Kyiv. It was very hard time, and this time I went to work to clinic where surgery wasn't very popular. It was therapeutic departments. Main things what I did, my main job what I did every day, I looked after arthritis of elderly patient under 70 or 80 years, and it was very boring for me because my internship was full of surgery in emergency clinic in Kyiv and Institute Orthopedic and Trauma and 9th clinic, city clinic number 9. It was very good time, lots of interesting operations, and there I went to this place. But thanks for my friends, they helped me in 2008 to get a place in outpatient clinic. It was much better because I worked with much younger patients. I have seen patients with trauma, not with only chronic diseases, and it was in Kyiv because previous place of work, hospital of Patriotic War, was abroad in Puszcza Wodice, if somebody knows, and it was more close. Moreover, in this outpatient clinic was trauma point with acute trauma. It was very close to me. And in 2011 I got two places of work. First place it was work in National Cancer Institute, and second place it was National Academic Opera and Ballet Theatre of Ukraine. There I was a trauma doctor, and I looked after after ballet dancers, and it was good time of photo. You probably can see photo with some artists. It's very good to speak with people like this. You become to be, I think, more sincere, more soft, and it really good influence on people if you go to see it, of course. As I told, in 2011 I went to work to National Cancer Institute, to Department Oncology, Orthopedic, Skin and Soft Tumors, where I work at the moment. In from 2015 until 2020, I worked on my dissertation on the topic choosing of optimal tactics of surgical treatment in patients with pelvic bone tumors. It is a huge job. I'm very thankful my scientist director Anatoly Detkov. We did really great things. And from 2013 I began my traveling around the world to get some experience, and as I told you, I worked as a ballet trauma doctor, and in 2013 we had a trip to Japan, and before going there I wrote a letter to one clinic that I decided interesting for me, Clinic of Cancer. It is Institute Hospital of Japanese Foundation of Cancer. I wrote letter that I will be in business in Japan and may I visit clinic to get your experience. They answered yes, and few days I was in this clinic. As you understand, it was very easy to get there. In 2014 I first visited Institute Rizzoli in Bologna in Italy, and then was lots of different courses in Ukraine and abroad, but I would like to put attention on some main interesting. In 2016 I have visited Institute Rizzoli in Italy. It is as I believe, and I think not only me but lots of colleagues, that in the world you can know the two main centers that treat orthopedic oncology tumors. Clinic Mayo in United States of America, in clinic Institute how to say correct, Rizzoli Orthopedic Institute. So in 2016 I went there and I began to travel with my wife. She is here, her name is Katya, and in 2016 she was second time with me in traveling, and very often we go together. If you will be a doctor, you will understand that you don't have too many time to travel separately on the conferences and weekends with your family, and sometimes it is very nice to take it together. Good tweaks, you know, you travel and you take your family, you get experience, you get emotions with speaking, with food, with sea and everything what you know, and you meet all different colleagues and you meet different conditions. You can see on this picture it is changing room that look into 2016, very nice in modern European clinic, and you can see a good examination room patient. But if you come back to Ukraine, you can see no photo here. One more photo should be. No, it is here. Okay. So Bologna finished. Next slide. In 2018 I visited first time cadaveric courses. If somebody doesn't know what is it, cadavers, it is dead people before they sign some papers, and when they pass away you can use their body to study and work on your skills. And sometimes you can see very interesting cases that colleagues presents, and I would like to show you this case. It is job of Professor Ruggerius from Padova. Patient had a tumor of hand and metastasis to the axillary region and they moved and put elbow on the region of the shoulder, completely different. Sometimes you cannot imagine what somebody does in the world. That's why you have travel and share information, and take experience from somebody who did it before. My last internship, it was in Bursa in Turkey, in Professor Kayhan, man in blue suit. I like Turkish people. I think that they like me too, because they really sincere. They like to share information. They like to accept Ukrainians there. And it was very good time for me in the summer. And you, of all time, when you come to abroad and come to Ukraine, sometimes you get sad because you can see that in 21st century, some examination in Ukraine, it's too poor, and it makes us sad. And today I would like to remind my biggest teachers, that people that I speak now, that I had opportunity to know them because somebody passed away. But today I would like to remind some nice people. First one, it is Professor Talko. It is an anatomy teacher of Kyiv Medical University. He passed away, but he was very good and popular among students who knew him like a sincere person that showed us real anatomy, lots of surgical cases and life experience. Second guy, it is PhD Honda. He was neurosurgeon and teaching in our university, and for my whole life I remind his phrase: if you don't want study, go to the market and sell bananas. It is your decision. And you know, all times this remembered. Second phrase that I remember from him, it is, dear students, don't forget that if you are doctor in Ukraine, you will have a roof under your head and you will have a car. Just don't worry, keep going, study. Another professor, it is my good friend and teacher, Panasiuk Alexei. He is a professional in tuberculosis, and he tried to teach us of clinical things, how to manage and differentiate lots of cases in the thoracic and lung disorders. Third guy, it is Grigory Soloninka. He is already feels good. He works in this university. He is my very close friend. We all time discuss lots of cases, and this man, I feel that when I speak with this man, that my alma mater, my university is close to me. I all time interested in how is going on, how is students, how is buildings, how is conditions. It makes me happy. Other guy, it is Kalyuzhny Gennady. It is my teacher from emergency clinic, from my internship. He did a lot for me. It is man who took my hands, my fingers to the bone and showed it how to do. It was, very easy. If your relatives, your father isn't a doctor, because very often dads teach son how to do it, and Kalyuzhny, it was like my dad in trauma and orthopedic. Also, for example, Dr. Alok. It is a very popular in Ukraine doctor. He is from India, and I worked with him from 2008 until 2010. He is a really professional doctor in orthopedic and trauma, and I very thankful him. And I keep in touch with him, of course. We speak, and I think we are good friends. Other guy, it is Sergei PhD Boychuk. It is doctor. I began my oncology orthopedic experience in National Cancer Institute exactly with him. I very thankful him. Other man, it is Professor Dudkov. It is my scientist director. It is we did my PhD together with him, and he gave me lots of good things, tips and tricks in orthopedic, and we worked together until today. And tomorrow. I think so that very long. And other guy, it is Professor Korovin Sergey. He is my chief in soft tissue and skin tumors, and gave me lots of good experience. Other, it is my general department, Igor Volkov, and very experienced researcher. We did lots of good things with him. Other guy, he's from Italy, from Bologna Institute Ortopedico Rizzoli. I was on a fellow of him. Why I like foreigners? Italians, they are really open person. They share their experience. The same like David Maria Donati. He is general department in this department. And my last teacher, it is Kayhan Turan from Bursa. I was speaking about him few minutes ago. Really sincere man, and it is for me was very difficult to understand. Sometimes Professor Kayhan examines during a day about 100 or 150 patients. He has a very good professional team, and I was there to take experience how to do. And I think that my list of my teacher or your teachers will be very big, because if you speak with many people, you get more, like this. What I treat now, I treat arthropathy. I'm interested in replacement of the hip and knee joints, benign and malignant tumors of bone and soft tissues, and of course I work in many clinics in Kyiv, but I hope so that very soon I will work in some clinic, because it is market and such situation that if you would like to get successful, you have to do a lot in this country. And I think that in your countries it is plus minus similar. And I would like to give you my experience. Maybe it will be useful in your country too, how to find your way in medicine. Why we are here, why we are doctors, sometimes it is very difficult to say, because I think that doctor's profession, it is not a profession, it is a lifestyle, and too many things have to get together and make you who are you. So it could be your conscious choice, because you decided to be a doctor. I don't know, it maybe child dream, maybe somebody influenced you and you got or met some doctor and you would like to be the same. Sometimes family choose who are you and where you have to go, and sometimes it is good, but sometimes it is not good, because I know that doctor, his families, they all are dentists, and they came to medical university to become a dentist. He passed education, then internship, and bring a diploma and put on the table and say their relatives thank you, and now he is a lorry driver because it wasn't his decision. Sometimes it is funny that it is more often girls, they go together to go to medical university, because she decided and I decided, we are friends, and it is a not bad idea, but sometimes it's wrong like that. It was easy to enroll. Sometimes it is easy to enroll because you can be a doctor much cheaper, for example, in Ukraine than in United Kingdom or US, and it makes this profession much close to be realized. And it is not about foreigners, it is not about students from abroad, but for Ukrainians sometimes it is very important, because medical university was in your place very close from your house, and sometimes people choose education like that. And it is my opinion, I don't know your opinion on somebody's opinion. It is my opinion about advantages and disadvantages of the profession. Advantages, it is really an important mission. You do a very big job and you can see happy faces of your patients. You have status. People like to see a doctor around the table, to have a friends doctors, because these people, it is intelligence, and in Ukraine now doctors' intelligence become to be more popular, but it is not the same like for example in United Kingdom or United States of America or Canada. You have a much higher status than in Ukraine. Sorry, something wrong, it is not correct translation, but I try to explain, translate you, that you use your status, that you are a doctor. Sometimes in Ukraine, much easier to get a kindergarten for your kids if you are a doctor. You come to kindergarten, say, yeah, I'm a doctor. Okay, we can take your kids because somebody from workers has a problem, for example, with knee or the shoulder, and it is very good to have parents of your kids that they are your doctors. They can manage your troubles. And of course, income. Doctors' income very, depend on country and your brand. Who are you? I know lots of guys in Ukraine that earn the same salary like in Poland, Germany, United Kingdom, and moreover, if they have private practice, you can have a good income. And I think in your countries you can get to, of course, good income if you are a professional. And of course we have disadvantages. It is irregular working day. Of course, you know that you can have a shifts 24 hours. Sometimes my family don't see me, my family doesn't see me for 36, sometimes 48 hours I'm in clinic. Sometimes I need to run, it's 11 o'clock in the night, but your family have to understand it and accept this, is that you have irregular working day. Of course, you can get infection diseases, and when I came from United Kingdom, I had an idea to go to work as like a nurse in hospital, but my mother, she is a nurse, and she recommended me, do not go. You are not experienced, and you can trauma your finger by a needle and get some AIDS or hepatitis or something like that, and maybe it is not good. But anyway, be careful, because lots of doctors was infected and get infected in the world every day. Use official position. I don't remember exactly what I mind about official position. Next, conflict in family. Conflict in family beginning from irregular work. If you have irregular work, you begin to have a conflict. If you don't watch after your kids, you can get conflict, because it will be two families. One family in clinic, your patients, your colleagues, and other family in your home, and you have to variate how to flight and to make all of them happy, because it is very important. And everywhere we have many not very friendly colleagues, but we have worked together and try to be good for everyone. In Ukraine, we don't have a lack of legislation and insurance of doctors, and it is very difficult if you have some diseases or some problems with lawyers or patients. And of course you have to study all your life, because medicine goes day by day further and further. If you don't invest money, if you don't go around the world, you will stay on the same position. You will be not so professional like your colleagues that travel everywhere. who remains to work in Ukraine. And maybe in your countries the same. It is patriots, people who really like country where they were born. Family dynasties, it is family of doctors, because it is very easy, your father, grandfather and all your family in medicine, and it is very easy for you to get the same, to share experience and work together. True leaders, it is people who don't afraid some troubles, problems, conflicts. They go further and they can get the aim everywhere, and they can survive in any country. And real victims who afraid to go somewhere, they will stay on some small position, sometime in the small, very small, low salary, but in the same place. Those who feel good, sometimes people have income from some other business, doctor profession, it is like a part-time job, just for fun, and they stay and work in the same country. But sometimes we have cases that people, those who are ready but too late decision. You know that if you decide in 40s that you want to go abroad, sometimes it's too late, because you need to nostrificate your documents, everything, but you have family here, you have friends here, and when you begin to study, for example, I tried to study German when I was 35. It was very, very difficult, it's impossible, and I really was lazy, and I stopped to do it, and I decided to little bit improve my English and at the moment stay in Ukraine. Who goes abroad? Those who are tired of fighting the system of medical development. It is conflict of interest between colleagues. It is absence of real system of education of young surgeons, like young doctors, and sometimes they don't want to fight and go abroad where system much better. Those who want to, maybe it is not a net salary, because I worked with the Google Translator, but I mean the clear money that goes on your bank account, that don't come on the table like a present from your patient. Those who don't want to sell themselves, you know, now in Ukraine lots of doctors sells themselves. Me too. Now I sell themselves because I would like to share information about me, share information about my specialty, share information about some experience, and I think that I do a good job, and my popularity will bring patients and good reputation for me. Those who value social package. I mean, if, for example, in Germany, it is you don't need to pay money for kindergarten, for school, for medicine, and it is the main point why people sometimes go to work abroad. Those who don't want to hear about personal growth, social networks, website and brand of the doctor, what I do every day. Sometimes I tired, I want to stop it, but you know, if you don't work, don't do nothing, you will get nothing. It is a system and times that we need to do everything what I told you. And sometimes people go abroad, those who want to work up to 65 in one position. It is a traditional that doctor go abroad from his one's country and work on the same position. It is very difficult to abroad, but I know some cases, but in that classic situation, very difficult to get a position of general of department, professor, chief of clinic, because these positions normally in the local people, local citizens. Why didn't I go? Why I stay in Ukraine? I work in United Kingdom. I visited many countries, but I had no decent offers really. I had the idea to go to Germany, I had idea to go to Poland, to United Kingdom, but I think so that I love my Ukraine, because you need to do lots of many different things if you would like to go abroad. I mean, pass your exams, everything, but it needs time, 5, maybe 10 years to get, for example, the doctor's degree in United States of America. But during 10 years in Ukraine, you can get lots of surgeries, lots of patients, lots of experience. And moreover, I have many good friends and relatives here in Ukraine. And I really believe in medical care in Ukraine. Believe me, it is much easier in Ukraine to get a private practice than abroad. And the main aim, my aim, I dream about my own clinic, and I hope so that very soon I will do something like that. Conclusions from this part of our lecture, our presentation. Each of us has a reason to be a doctor. Unfortunately, there are many disadvantages of the professions, and understanding of the cases of migration give us the understanding of the future strategy, where you will be in the 5 or 10 years. You have to think and dream about, for example, surgery, dream about trauma, and build your steps like this. For example, I dream about trauma every summer. I went to the clinics, to the traumatology orthopedic department in the small district, and get experience, try to put stitches, try to put plaster and everything. Begin to do your profession now, not after finishing of the university and the beginning of your internship. And now, other part, it is a neoplasm of bones and soft tissues of extremities. About 90% patient that I treat every day, it is such group. Other 10%, it is a patient with arthritis, broken bones, and patient without tumors. And this lecture will be about neoplasms. The most popular neoplasm of the bone, it is osteosarcoma, and I don't know actually you know or not, but osteosarcoma, it is the oldest malignant tumor. The legend that malignancies and cancer and oncology, it is a new diseases, it is not right, because in 2016 the remains of skeleton on ancestor man was found, and it was about 1.7 million years ago this human passed away, and South Africa and colleagues found tumor in foot bones in this case, you know, can you imagine? And with 3D reconstruction they investigated that it could be osteosarcoma. Another case found the bone of Australopithecus, of ancient humans, that had a hemangioma, probably hemangioma of bone, benign tumor. If we speak and would like to have some understanding about bone sarcomas, we have to know risk factors and some syndromes that can influence on significations of some disease. First of all, it is Lee-Fraumeni syndrome, genetic disorder of mutation P53 gene. Other, it is Rothmund-Thompson syndrome, rare autosomal recessive disease manifested by damaged skin, bones, teeth, and others. Another, it is Bloom syndrome. I have seen in my life few patients with Down syndrome, and also with the tumor, malignant tumor of the bone. And Paget disease, it is a multifocal bone lesion, benign, but sometimes some of these nodes can get malignancy in 1% and become to be bone cancer. Other it is factor, it is previous ionizing radiation, radiotherapy. Ionization radiation, we speak about, for example, Chernobyl. About radiation therapy, you have to know that sometimes we can get an influence on tumor by gamma therapy, and in long follow-up, 10 or 15 years later, this patient can come to you with a tumor of the bone. For example, if patient had radiotherapy on the tumor of, for example, prostate, bladder, or rectum, and then you can get, you can see and investigate bone sarcoma of pelvic bone tumor. According to National Cancer Registry in Ukraine, if you have to know that in every one country has a national cancer registry, like in Ukraine, and you can read it, of course, in English too. National Cancer Register publishing in National Cancer Institute, and you can watch how many cases yearly we have. And for example, in 2012 we had in Ukraine a little bit more than 400 primary malignant tumors, but it is only primary. We don't speak about metastatic disease from other cancer to the bone. We speak about primary bone tumors. And not a big difference between men and women. You see 223 and 205. And according to the National Cancer Register, in 2013 in Ukraine we diagnosed about 1,760 cases of malignant neoplasm of soft tissues, so soft tissue sarcoma, and together it is about 2,000 cases, and that's why my specialty, it is very, very rare in these cases, not too many in every one country, the, how to say it in English, the quantity of patients in the world is a plus minus same, depends on population, but epidemiology very similar. Histological classifications, I can put a big book with a histological classification of primary bone tumors, not metastatic lesions, and it is lots of information, but I try to show you just one slide for a little bit understanding of this problem. First group, it is bone-forming tumors. It is osteoma, osteoid, osteoblastoma, and malignant osteosarcoma. Cartilaginous tumors, chondroma, osteochondroma, chondroblastoma, and others. Giant cell tumor, it is benign lesion. Other group, it is bone marrow. That is tumors that grows from bone marrow. It is like a Ewing sarcoma, reticulosarcoma, myeloma, lymphoma. Tumors as a group from vessels, vascular, hemangioma, lymphangioma, angiosarcoma, and lots of others, but I got to this presentation the most important, and this that we see very often. And other, it is connective tissue, desmoplastic fibroma, lipoma, everyone knows, fibrosarcoma, and sometimes liposarcoma. And tumor-like lesions, benign, it is aneurysmal cyst, solitary cyst, fibrosing dysplasia, metaphyseal defect, granuloma, Ollier disease, Volkov disease. Lots of them, but if you are interested in, you will share, you will go further, and every one group you can read for a month about every one tumor. If we speak about structure, sorry, this slide I didn't translate into English. May I show here? The biggest piece of pie, it is osteosarcoma, about 43%. Little bit smaller pie, it is chondrosarcoma, 22%, and sarcoma Ewing 19%, and much less quantity of primary bone tumors. It is fibrosing histiocytoma, fibrosarcoma, and others. Localization, if it is a picture from a book from Rizzoli Institute, it is a very big institution that gets lots of cases around the world, and they show some interesting statistic, and I will put your attention on some of these statistics. You have to be very careful when you see patient in age from 10 until 19, because in this age very danger to get bone sarcomas, the most danger age. Then you can see that quantity of benign bone tumors of the bones may go down and down, and put attention on this age. Other thing that you need to put attention on the problems that patient come with problems around the knee. You can put and make sure that patient doesn't have, patient doesn't have a lesion or tumor of distal femur, distal thigh, or proximal tibia. And of course, lots of tumors localized in the pelvic region, in the scapula, and very rare cases of primary bone tumors in the cranium bones. The same like I don't know in English. I know only in Latin it is sternum. Know somebody how to call sternum? Sternum in English. All right, read how translate sternum in English language. Anyway, you can fix this picture and watch and research it, but everything it is very interesting. Histological classification of primary soft tissue tumors. Lots of them, but some difference that you can see here from some group. Here you can find neuronal tumors, but sometimes neuronal tumors can be in the bones too, very rare cases, but classification, I don't want to stop on classification, because if you watch first time lecture about musculoskeletal tumors, you will not remember this, and you will, if you will be interested, you will study it further. How to diagnose bone tumors or soft tissue tumors? You have to understand that standard of investigation of both tumors, it is radiography, X-ray. First of all, what you can do if you suspect some lesion in the bone. Later, you can perform an MRI. MRI shows a very good lesion intramedular. You can see a good margins that you cannot see so exactly like on a CT. Sometimes this picture, and if you are beginning doctor, sometimes they look very similar for you, and you cannot understand what is different here and here of this lesion. But if you will go further, you will understand you will open the world of imagining for you and understand pictures of MRI and CT. As an investigation, for example, it was used for a patient with osteomyelitis, and it shows very good inflammation. You cannot see inflammation so good on X-ray, but on MRI it is very nice demonstrated. As a type of diagnostic of bone tumor, it is osteoscintigraphy or bone scan as the name of this procedure. It gives us opportunity to investigate all skeleton from a cranium until foot and see everyone metastatic or primary bone lesion everywhere during one procedure, but it is only specific for bones. It is not specific for soft tissue or abdominal or thoracic, parenchymatosic or all other organs that localize in our body. And CT, in most cases, when I perform CT for patients with oncology, if I do a follow-up, or if I would like to make a 3D printing, because now you can, for example, you see on this picture a lesion of pelvic bone. You can give it to the laboratory, they can print it from plastic, they can print it from CT to metal and to do implants. As a diagnostic, it is PET tomography that very specialized for follow-up or diagnostic of every one cell of our body and can show oncology on very beginning stages. And you have to remind the main point from this slide that all time, if you perform MRI or CT for patients with oncopathology, you need and you have to insert contrast intravenous, because only investigations with contrast will show us good imagination and understanding of oncopathology. For example, if you don't insert contrast for patients with lung metastasis, you cannot see them. But if you do it, you can see everything and make your job much better and get a better result of treatment of your patient. As a step after MRI CT, you have to you need to prepare biopsy. Biopsy could be thick needle. If you take a needle little bit bigger than classic syringe, and you can aspirate a bone marrow or consistation of tumor from bone or from soft tissue. Or other type, it is a trepanation. It is little bit bigger tube, but you can go inside of a strong bone and get everything what you need. And in some cases, if you didn't get material of tumor from by thick needle or trepanation, and material is not informative, you cannot make a diagnosis. You need to perform open biopsy to cut, to remove, but all time you have to remember, then later if you will do a surgery for this patient, you need to remove this biopsy tract. It is very important, because sometimes people do it biopsy tract in some places that very difficult to remove in next operation. As example, patient was operated in other clinic, not by me, and patient got recurrence of tumor 1 month after operation, and you see that wound scar looks like this, and for a radical surgery, for a good removing, you need to make a very wide excision and very big deficiency of skin, and then to perform a plastic surgery to cover muscles, to cover bone. It makes our job much harder, much worse. Basic principles of treatment of primary bone tumors, we can divide them on two main groups: high grade of malignancy and low grade. It is, you see this G1, G2, it is result of histology conclusions that shows if in this case we can do only operation. In this case, if you have histology classification G3, G4, you have to perform first of all chemotherapy, then do operation, radiotherapy, and do chemotherapy after surgery. It depends on level of dangerous of tumor. If tumor it is not very dangerous, we don't danger in metastatic metastatic disease, we don't need chemotherapy. If such a case of tumor can do metastasis, of course chemotherapy have to be performed. Basic principles of treatment of primary malignant tumors, it is really discussion for lots of colleagues and congresses around the world, but this picture shows the main idea that can be useful for you, and you can just understand what can be with such group of patients. We can divide them on two groups as a radically operable. What is radically? It is a tumor that you can remove everything. Don't leave something near vessel, don't leave something near bone, but remove everything. And radically not operable. It is big tumors that localize near vessel and nerves bundle, and you cannot remove it or cannot remove with a leg to perform an amputation. And in these cases, if we have radical operable, we can do surgery and then prescribe radiotherapy or follow-up. If we have big tumors, we need to perform chemotherapy, radiation therapy, and then surgery, and maybe then chemotherapy. But it depends on, because we have hundreds of different types of soft tissue tumors, and every one localization, hand, foot, thigh, shin, in all time we discuss it and decide the way for personalized for every one patient. It is a very simple picture that shows just the principles of tumor removal. Could be just a intralesion, small excision, marginal resection, wire resection, radical resection. But for every one part of our body, it is individual, and we have to discuss the way, but it shows you just as the main principle that demonstrated on the musculus rectus femoris of quadriceps. And if we speak about tumors of extremities, we are afraid an amputation, and we like to perform limb salvage treatment. In most of cases, about 90% of patients we can do limb salvage, but about 10% in Ukrainian around the world, this group of patients get an amputation. But main criteria for limb salvage treatment that local lesions should be available for radical resection. I mean that we can remove all tumor. If we cannot remove tumor and we are afraid that something will left, we need to perform amputation. And rescued limbs, saved limbs must be functional, because sometimes we need to remove lots of muscles, and then extremity, hand to leg, looks like a prosthesis, not functional, but the main idea to leave patient the limb, and the function should provide good quality of the life. Relative contraindication to amputation, it is pathological fractures and skeletal immaturity. But sometimes we discuss it, but we have to know and understand this what I told. And nota bene from this slide, the presence of distal metastasis not contraindication for surgery or limb salvage. And with next slides I will speak about life prognosis and metastasis and everything. I think that should be interesting. As for survival results, for example, sometimes patients and relatives and world thinks that patients with sarcoma cannot live, but I'm very happy that we have this result, but I believe that results will be much better year by year, because scientists and medicine go first. For example, here, you can see that survival from a by patient with localized osteosarcoma 5 years, it is demonstrates 77%, but 33% of these patients will die. But moreover, during first 3 years die the main group, about 30% from this 77 will die by first 3 years. So most dangerous period it is 3 years. Then if patients survive after 5 years, they can live more 5, 10, 20. But the most important to have correct treatment at the beginning. Chondrosarcoma has a better result. It is 91% localized, and all stages you see common combined result, it is 80%. And as for Ewing sarcoma, localized result 83. But with distant metastasis and all group, you see that results twice lower. But and one more interesting thing is that until 90s, the survival for patients with the localized sarcoma was only not more than 30%. But I'm very sad that in the world not too many modern drugs for treatment of bone and soft tissue sarcomas in compare for a patient with lung cancer, melanoma or gastric cancer. Sarcoma cancer and metastasis is not always a verdict, and it is, I would like to share with you case. For example, lady came to our clinic. Before my coming there, her treated by other colleagues, but I met her in 2014. That story like this: in 2001 year, he was diagnosis the osteosarcoma of the lower thigh of the left femur. She got combination treatment, neoadjuvant therapy. If somebody doesn't know, neoadjuvant, it is preoperative chemotherapy. And then tumor removal with left knee arthroplasty and postoperative adjuvant chemotherapy. In 2004, she got lung metastasis and chemotherapy and surgical removing of the tumors from the lung was held. And in 2006, she gave birth for a healthy baby. But in 2011, in 2014, she got other problem with her endoprotesis, because oncology, you will see a little bit later how oncology endoprotesis looks. And sometimes we need to do renovation very often, and for a patient who walk for 10 or 15 years, they need to have other surgeries. But interesting that she got multiple sclerosis. I don't know why, from stress or from chemotherapy. But she's still alive at the moment, of course, too. And I would like to show you survival result in patients with metastasis, and you can see that, for example, patients with breast cancer, about 20% of them that can survive with fourth stage during 5 years. Other diagram demonstrates patients with rectal cancer. It is you see that the quantity is lower and lower quantity of patients with lung cancer, but anyway that can live. And in cases with the bone metastasis, we perform surgery for these patients. We help them to walk and to feel better in their lives. Indication for surgical treatment. Sometimes why in my lectures I speak about this problem, because many doctors and many people think that if patient has metastasis to the bone, it is the end, it is a finish, but it is not a true. We can treat this patient, they can live and survive. And it is a scale in English, in Ukrainian language, but I will explain you that you can count a quantity of 1, 2, 3. For example, how many metastases has patient, did patient, chemotherapy, type of tumors, and then you can count quantity of the quantity, and then you can quantity of points, and you can decide what kind of treatment you can perform. It could be radical, can be palliative, or really surgical treatment. It is not indicated. And of course, in these very difficult strategies, in these very difficult cases, we need to have multidisciplinary team. And it is NCCN recommendation that in clinics have to be lots of different specialists that take part in decision of way of treatment for every one patient. So why we have problematic issues with bone and musculoskeletal tumors? The bone has a multi-component structures, as you know from anatomy of histology. Bone can have vessels, lymphatic vessels, classical, fat, nervous, and everything. In bones can be infection, and sometimes very difficult to make a differential diagnosis. It takes time, tumor grows, and results, of course, not so good. And in about 60 or 85% of cases, we have errors in observed, that not correct diagnosis. Lots of us, we think that patient have Osgood-Schlatter disease, lipoma, just deformity, but it is not tumor. First of all, if you see deformity, pain, night pain, different in the size of extremity, you have to think about tumor, then about other diseases. And I'm sorry, but not correct to sorry, but it is a fact that medical staff and patients aren't familiar enough in the clinic of bone and musculoskeletal tumors. And each case is special, of course. Every day I see different patients that sometimes they treat 6 months. They think that it is an ulcer, but it is a cancer. They think that it is a hematoma, but it is a tumor, and they get not a correct treatment. Other case, patient fall down and was diagnosed like a fracture with displacement with some fragments. Okay, doctors put intramedular nail, locking, everything looks good. In 3 months they see a lesion here, something wrong, not correct. Okay, maybe osteoporosis, but few next months see a big lesion. It is not osteoporosis, and this patient came to me, but it lasts about 1 year, this situation, from this to this and to me. And I performed for patient CT, and I got lung cancer, not diagnosed it. And sometimes people think that it is a verdict, that first stage of cancer, lung, tumor of lung, metastasis to the bone, it is end. But 12 months later, it patient came to me, he walked without stitches, the condition was good, and I prescribed him zoledronic acid that made his bone very strong, very sclerotic, and very good effect on bone metastasis. Too really late diagnostic. For a patient, for example, with such big bone tumor on 3D reconstruction, and surgery have to be performed, an amputation with the pelvic bones. And this patient with a huge lesion of pelvis that grows into inside, and patient really came first time on the crutches, and in this session we couldn't do nothing. Moreover, I took this case to Italy to discuss with colleagues on a conference, and they said that the same situation abroad, they cannot do nothing. Other case that misdiagnostic, that's for patient with how to say, with the tibia bone. You see that here it is small curvation, small deformity, but doctors didn't put attention. It is thought that it is anatomical structure, but later in few months we can see the pathological fracture and big tumor. Later I performed an amputation for this patient. Sometime patient came in 21st century with big tumors that they follow up for 6 years, for example. Patient with a tumor, benign tumor of the knee and benign tumor of the finger, 6 years. You know, everyone decides what to do with the body. But sometimes situation can be managed in 30 or 40 minutes. One patient came to me with scared eyes, crying from other clinic because doctor suspected some tumor here, but in 40 minutes we performed CT. It is only anatomy, it is not only tumor, but sometimes better to suspect or do not suspect, send patient to some specialist that will do. But the main point of this picture is that if patient wants, if patient and doctor have such opportunities, we can diagnose it very, very fast. The main idea, it is the aim. Next. Next case of late coming to the clinic, it is a patient with squamous cell tumor. It is citizen of Kyiv with a stinky tumor. And first of all, what we wanted to do, it is perform an amputation, but then we decided limb salvage surgery, but with some complication, with some problem, because tumor is too big. We decided to perform wide excision with plastic free. Sometimes people decide to do with vascularized flap, but in this case we decided to perform autodermatoplasty with using of vacuum therapy. As you see on this picture, position, next slide, position patient of operation table. I'm like most of my surgeries I do with my very good friend Bogdan Maximenko. Hello, if you're here. It is our patient, and we remove such big tumor from humerus, and you see the soft tissue defect of the skin, and here is a radial nerve. Then we performed myoplasty to cover radial nerve, because you cannot put such bandage, some dressing vacuum, if you have a nerve inside of the wound. You have to cover nerve. Then we did an imposition of gelatin specific dressing, and then vacuum therapy. And we performed patient vacuum therapy for about 13 days, and you see a nice growing of granulation, and we prepared patient for dermatoplasty. And we suspected an infection in this tank of vacuum therapy because it looks gray. It looks like infected, look like infected, but we understood that if you show me предыдущий слайд покажите. Alexander, предыдущий. You see this is gray, and this bandage is gray, and sometimes it gives gray color in the tank. We just removed, and wound wasn't infected. That we did preparation for skin graft. By electrician tool we got some skin from thigh and remove it on the humerus and put it vacuum therapy for the next 5 days. And in next 5 days, наступный slide. Next 5 days we could see in men that age over 70 is a very nice covering of the defect. If somebody has experience with the skin graft, the percent of live skin it is much lower, but vacuum therapy gives us opportunity to press skin graft to the soft tissue, and in this way to still alive and to be growth to the normal tissues. In 14s you see the result, and you see the result in 42 days. It was very good. But if somebody knows what is that squamous cell carcinoma, it is tumor that can show very many recurrence cases in this patient too. But the main idea that vacuum therapy can be useful for a patient with big soft tissue and skin defects. Slide for a discussion that we have now not in this case, but now to prevent recurrence we use a micrographic MOS surgery to achieve radical surgery. I don't know if this patient could it help, but now if I will have the same patient, I will perform MOS micrographic surgery. Oncology and endoprotesis, they are really different from simple prostheses that we use for patients with arthritis, because they have a much bigger size of metal that removed, and during of surgery much bigger, and quantity of resected bone of course much bigger. It is a case for patient with recurrent chondrosarcoma. We put modern Mutter's German endoprothesis, and in this slide I would like to show you some complication, because if you don't have a complication in your life, you are not surgeon, and when you will go more further and further, you will have lots of complications. But it is a life, you cannot prevent everything, but you have to know how to manage this. In this case was necrosis of skin flap. We did skin and soft tissue nephrectomy, put vacuum therapy, and then after 5 days we got nice wound cleaning and healing during 2 months. It is a result in just 5 days vacuum therapy. You cannot get such result on any, my experience, on any other treatment with soft tissue necrosis. Other case, it is with the neurosarcoma of soft tissue in the other elderly man, 82 years. You see that tumor grows into the skin. We removed big piece of skin with the tumor. It looks removes tumor with marked margins here, and you see the skin grafts that we put here. And again, one more case with the vacuum therapy. You can see the machine for vacuum therapy that try to fix skin graft very close to the muscles. And you can see the result in 5 days, 10 days, 20 days, 28 days. But you have to understand is these patients that in this age, in general, it looks not very good, but in this age, in this case, who has experience knows that it's very perfect result, and it very is good. And donor site looks like this in these patients. After skin removal for about 14 days. Other case, I very like system fiction intramedular nails for a patient with pathological fractures, because it is very easy to insert. Video, please. You just need to perform a small skin cut about 3 centimeters near. No, not this video. Video with video з цим.
Чудово, поворачуйтесь, ручкою помашите.
Yeah. You can see, but another way. But it's okay. You see that you can get inside by a hammer very fast this nail. This surgery lasts for about 20 minutes. You insert intramedular nail inside. One more time. Ще раз дивимося. Don't worry. And then you see that I do in my hand, put a voltage drill inside of the screw and of the nail, and this nail becomes to be wider. It goes wider, and it gives very good fixation, and patient can walk 2-3 days after surgery. I know that you have seen walking ladies few times. We don't need to put this video anymore. So, and you see that I did it for a thigh and for a pathological fracture in tibia. Invite patient in 1 hour 2 bones. Наступний. Excochleation of aggressive curettage. Cases of kidney metastasis to the proximal tibia, you see lesion, and removing and replacement by bone cement and metal screw. As a case of a bone cyst, they sometimes grow from the bone into the soft tissues, removed and performed alloplasty. Alloplasty, it is a bone that come from cadaver or from femur neck of patients that held hip arthroplasty. As a case, it is excochleation of chondroblastoma with combination plastic of the proximal thigh and metallosteosynthesis. And on the video, you can see patient walk. Patient can do movements in her joint. Just a moment. But if we speak with these cases, I'm very sad, but she got recurrence this week, and probably we will perform arthroplasty, total hip replacement in next few weeks. But result was functional, was really very good, and I think so that we will get the same result after hip replacement. But recurrence in patient with chondroblastoma, of course, can be. Curettage of enchondroma. Sometimes we meet patients who come. Next slide. Curettage of enchondroma. Patient was in other clinic, pathological fracture with benign tumor inside. they performed only, took small piece of tumor and put plate on the top, but she came to me and we removed plate, removed tumor, put allografts everywhere, put again. So sometimes colleagues do wrong things, but you can save, if you will be smart, you can save a patient's time, patient quality of life to perform in order perform it one surgery, not two. Sometimes we use cryodestruction. We put inside of the bone where we just remove the tumor, hydrogen, and perform cryodestruction. It looks like a magician inside. The temperature of hydrogenic cryodestruction is minus 180 degrees, and it kills some cells that could be inside of the bone.
А зачем ти ту леєчку сюди ще ставив? Так треба, так? А ну хватить. Все нормально. Так, можно подвигать еще немножко. А возьми еще с бокового ракурса.
Next slide. And in extending talk about surviving patient, this lady, she suffered from lung cancer more than 5 years, and 6 months ago he came to us the clinic with a pathologic fracture of the bone. They confused her in surgery because they were thinking that she will not live, but she's still alive, and I hope that she's still alive now. And we performed for her segmental resection of this bone and put screw plates and some metal stuff inside, and she shows perfect result during 2 weeks after surgery. You can see the dress on your humerus, stitches already there, but she has a very good result. Just a second, you will see a video.
Поднимаем ручку сколько можем, в локте сгибаем, затылок чешем. Отлично, хорошо, опускайте.
Next slide. The case of chondrosarcoma of the humerus, you see that big lesion with it looks like bigger than here, you know, it is chondrosarcoma. We did a segmental resection of this and put her fibula from here to here, and you see that very good results about 1 month after surgery. Video. And I have seen this lady few months ago. She feels good, and the function, it is the same.
Піднімайте вверх, в сторону, за спинку, перед себе, до себе. Всім машемо ручкою.
Great. And very rare cases of that total chondrosarcoma of humerus. You see that tumor grows from neck and intramedular channel until all humerus bone, and we did the extirpation. If you see my colleague Bogdan in his hand, wall humerus with soft tissue component, and endoprothesis here with the mesh for a better muscle fixation, and you see the X-ray result. I'm sorry I don't have a video for this patient, but believe me that in patients who underwent such type of surgery, they cannot lift up hand like this. They can do like this, because all rotator cuff was cut off from a humerus, and this mechanism of movement, it is impossible. Case of giant cell tumor of distal radius, you see. In this case we removed proximal part of fibula and put it here and fixed by metal titanium plate and screws. The case of resection of the humerus and with endoprothesis like this, and I would like to show you the most often complication video, please. Complication, it is a dislocation of endoprothesis, but you already know from previous slide that patient who underwent surgery on the shoulder here, they cannot lift up, and this small dislocation, it is not very influence on function of elbow and wrist, and this pathological movement plus minus okay for these patients. The next slide, it is a result of giant cell tumor of the proximal tibia, reconstruction by Ukrainian made endoprothesis. As the case, it is little bit bigger than you've seen before, mutas, big replacement of the knee. Classic surgery, oncology, orthopedic, it is scapulectomy, removing of scapula. You see position on the table, and you see that defect, it is humerus head. Here should be nervous and vessels bundle, and this is here skin flap, and you see the removed scapula with a soft tissue component. And I would like to show you cosmetic result, how patient lady looks after such kind of surgery. This time I used this green antiseptic, very popular in our country, but now I don't use it anymore. But it is history. But I would like to show you video how she looks. Yes. The same case, patient after scapulectomy, they cannot lift up the hand. The main idea, it is a safe of movement of elbow and wrist. Next case, it is a knee arthroplasty by Ukrainian endoprothesis. You see a huge tumor here with of the knee with big soft tissue component, and result of reconstruction by Ukrainian megaprosthesis. As a prosthesis of the humerus, you probably know or heard about some arthritis endoprothesis. In these cases, we remove with arthritis only head and neck of thigh, but in cases of tumor like here, we need to remove big part of bone and put big tumor, and with a long stem until knee joint. And on the video you can see result how walk patient after oncology endoprothesis. It is good result, but sometimes patient with such endoprothesis can walk much better and without stitches too. Next slide. Marginal resection, it is very often surgery in patients with benign and malignant tumors of the bones. You can see a tumor here and result after resection here. Sometimes really rare case, you can see osteochondroma, benign tumors of the bone here, and on the top lipoma in the same region. What also we did, we removed these together and did resection of the ileum, and everything is good. I very like to demonstrate cases for patients that don't need any reconstruction. On this X-ray you can see that we removed the fibula. Here you can see cosmetic result on the skin, and you can see how patient walk without fibula.
І назад. Розвертайтеся. А, в принципі, окей. І то обличчям. О, чудово.
As a case, patient had tumors of the metacarpal bone, but she didn't want to have any complicated and difficult surgeries. She wanted only tumor removing with the bone. We did it, and you see that she has a very good result for her. She is happy. She is from village, and such result for her is very good.
Так, тепер згинайте руку. Пальчики. Ще раз. Розводьте.
But
Розводьте.
she doesn't have a metacarpal bone.
Згинай.
As a case patient without collarbone, without clavicula, and you see the video.
Значить, піднімайте руки вперед. Да.
She can do everything.
вверх,
It is not
повністю в
a
сторону. В сторону і вниз.
mastered surgery. It is classic surgery that performing around the world. But I saved this video to show you that patient without clavicle can have a very wide amplitude of movement and have a good quality of life. Next case, it is a resection of distal ulna, in Latina distal ulna, and without reconstruction. Chondrosarcoma was here, you know. Here we resected, and you can see such result.
По кругу ще раз вверх. Вверх.
Full movement. Moreover, this group of patients after distal ulna resection, they can take sport, workout, and everything what they like. And amputation. I didn't perform for you all type of amputations that we can do in oncology orthopedic cases. I prepared the most difficult and most complicated is a case of patient with skin cancer here after radiotherapy, and you see the scheme of planned surgery of anything 2 type resection of a pelvic bone, and you see the result and flap how we closed this wound. A case with squamous cell carcinoma. But in some cases of pelvic bone tumors, we try to perform, of course, limb salvage surgery. It is a slide from my PhD, and you see 3D reconstruction with the lesion of a pelvic bone here. We did a 3D imagination of this case and planned it. It is physics, stress, strain on the different places, and model the optimal reconstruction system for this. Insert it, put bone cement like here, and you can see result of patient that walk 1.5 months after surgery.
Поїхали.
She cannot walk exactly correct because in every one case they have shortening
так.
in one
Праву
leg
ножку,
because
ліву
this
ножку.
type of
Повертаємося
trauma,
і
this
сідаємо.
type of surgery
Встаємо. Ручкою машемо.
caused pelvis dislocation, pelvis disbalance. Promising direction in modern oncology orthopedic, it is 3D modeling and printing. Next slide. If you remember from previous slides, I told that you can do CT for patient, then you can print it on plastic and perform surgery on plastic, plan everything, and then do it on patients. So do not perform experiences first time on your patients. It is case of 3D printed endoprotesis in Ukraine. I'm happy that in Kyiv we have a 3D printer, we have 3D laboratory. We did it together with my colleagues from Fania and Orthopedic Institute. It was held in Orthopedic Institute, removing of pelvic bone tumor and inserting of such kind of endoprotesis. Promising direction in modern orthopedic, it is growing screws. It is specific screws, or correct to say nails, inside of the bone and cut off bone here for a growing like Elizarov method, but without complicated dressing and follow-up for patient. It's much easier than Elizarov system. Other kind, it is carbon implants. In cases, for example, with pathological fracture, you can insert such carbon plate and then perform radiotherapy without risk of infection and risk that this plate will have a conflict with radiation therapy. And you already know about 3D printing from titanium. We have it already in Ukraine. We don't have tantalum treatment. Tantalum, it is different metal and different system that provides better connections with our bone, and bone can grow inside of this metal. And other pain, it is in Ukraine. We don't have a very good quality individual prosthetics. We have Ukrainian, but it can be better. I hope so that we will do something on our market. Take-home message: it is early diagnostic and histological affiliation are important prognostic factors. Only interdisciplinary approach, biopsy, remember risk groups, MRI and CT only with contrast. Sarcoma, cancer and metastasis are not always a verdict. No statistics, and you will have a much easier understanding of problem. Do not predict life expectancy. The human body can adapt to massive defects. Reconstructions, of course, not always necessary. And the most things that I all time say for my patients, that positive mood of the doctor and patient is the key to the result. Thank you very much for your attention and your time that you was with me. And if you watch these maybe recordings of this video, if you would like, you can get me in social media. Dr. Kostiuk, I don't know where is the last slide. Was picture from my Instagram? No? Yes? Є з Інстаграму така штучка має бути. Алло. Uh-huh. Oh yes, you see. Before we will show you QR code, or you can see my QR code. You can get my Instagram. I share the lots of information about trainings, about growing, about cases. I think that information should be interesting for you. And we have oh cool, we have 8 questions. Great. Yesterday was lecture in Ukrainian language. We didn't get any question. Shaherman and Ludvika, they have question for me. What year of studies of what's the year of studies of at Kyiv Medical University you were able to decide on which specialty you choose? Мається на увазі, коли я навчався, правильно?
Який рік навчання ви визначили з вашою спеціалізацією?
Ще раз.
Який рік вашого навчання ви визначили спеціалізацію?
Ага. I drum about trauma and orthopedic from second year of my education. Second, third year. I understood that I will work with bones. Why did you choose to focus on the oncology aspects of orthopedics? Because in 2011 it was very difficult to get job in classic orthopedic trauma department, not oncology, and it was way for me to find to go to big surgery. It is only oncology orthopedic. How satisfied are you with the treatment of your patients? Sometimes I'm very sad, I'm really sad, sometimes I'm real stressed, but very often I try to find some positive moments, some positive cases that make me happier and that keeps me in such direction where I am now. What are your predictions for the future approach in the treatment of both tumors? I think that, I hope that we will see more than target specific therapy for bone cancer. The main hope on this, not on the surgery, on chemotherapy. Are the gene therapies effective in bone tumors treatments? You mean probably target therapy. You know that bone and soft tissue sarcoma, they mutant much more than, for example, lung cancer, and very difficult to get target therapy for such gene mutations. And these kind of tumors usually resistant for such therapy. What are the biggest limitations today that you would enable better research on this topic?
Які є сьогодні взагалі обмеження в дослідженні вашої специфіки, вашої теми?
We don't have really limitations.
Maybe some legislation or законодавство?
Maybe some laws, and finances, of course. For example, I have ideas to perform some interesting experiments on rats, for example, but you need to have lots of money and everything, and for performing such type of investigation. It is budget limit. What is the process of developing new approaches on bone tumors treatment? How many people usually are involved? In Ukraine, if you would like to know and investigate this profession, in Ukraine you can find 3 institutions that do it. Is National Cancer Institute, where I work, Orthopedic Institute in Kharkov, and Orthopedic Institute in Kyiv. They have some experience, but the best idea go abroad to study somewhere, for example, to Italy. I strongly recommend. How much of your research regenerative medicine? How much of your research is based on the regenerative medicine? You know that, for example, regenerative medicine, it is platelet-rich plasma, PRP, for example, or hyaluronic acid, but it is contraindication to use for patient with a bone tumor. So, and regenerative medicine, it is not very useful. But in my PhD, in my research, I didn't have opportunity to do cadaver bones, but it is possible to have some research everywhere in the world with some regenerative, with cadavers, bones for patients with bone tumors. What is a vacuum therapy? Vacuum therapy, if you have a wound, for example, with a skin defect, you put there special dressing, and this special dressing has a tube that goes to machine, and this machine perform vacuum here, so not enough air there. And this vacuum therapy, lots of many different things. For example, it can take some exudation, infection of bacteria from here. Other way, you can make a pulse, like a pulse therapy. Machine can make a vacuum 120 millimeter hydrergium colon or 80, and do like this small positions there that makes bleeding blood vessels better, and granulation tissues and recovery can be with tissue. Other way, you can put a skin graft that I told, that vacuum therapy has many different steps. I have separate lectures about vacuum therapy, but if short we have not enough time, I think that my answer it is enough if it's short. I think that's it.
Yes.
The end. It is the end. So, thank you all of you that you were here, that you watched my video. I think that this information will be useful for you. And one more time, I would like to say thank you, my native Kyiv Medical University. Keep going, keep further. Good luck, everyone. Cheers. Bye.